Okay. Happy Valentine's to all. Sorry, malam ni yang kita kena buat kelas ni. I pun tak tahu kenapa Atika setuju nak buat kelas malam ni. Okay. Okay, first, given 4 topics under CVS today, we're supposed to talk about cardiac cycle, coronary blood flow, autonomic innervation, electrical activity. But we'll stop at number 3 lah. Cardiac cycle, coronary blood flow, and autonomic innervation. Electrical activity, in a whole day, we want to talk about all this. It's a bit too much for you all. Nanti unable to absorb. And electrical activity is best to be explained together with ECG on my last class. The one of my class in March, I think, with you all for the cardiovascular equipment monitoring, because it's very related. So tak perlu nak ajar sekarang, nanti lupa pula. And finally, we discuss about homework, and then we discuss few more rapid fire questions. Okay. So first, what is cardiac cycle? Cardiac cycle is one complete sequence of ventricular systole and diastole. At a heart rate of 70 to 75 beats per minute in a normal heart rate, each cardiac cycle, it takes around 0.8 seconds to complete. So one complete sequence of diastole and systole and diastole will finish in 0.8 seconds. So it has 2 phases, systole and diastole. The phases of systole is relatively shorter compared to diastole, which is 2 times longer than the systole. Systole consists of isovolumetric contraction. As the name suggests, you all must know this term very well. Isovolumetric means there is no change in volume. Okay. During the beginning of this phase, there is no change in the volume. Only the pressure builds up. So this is from the mitral valve closure to the opening of aortic valve. We'll go through it slowly. Just know these terms first. Second is isotonic contraction, which is isotonic means tone mean pressure in this sense. So there is no change in pressure, but there will be increase in or changes in volume. As there's systole contraction, there will be ejection phase and the left ventricular volume will reduce. This is a phase of rapid ejection followed by a phase of reduced ejection. Third would be protodiastole. As the name suggests, proto is just a phase before the diastole where there is no ejection occurs. It's a ejection has been completed and the left ventricular pressure starts to fall and the aortic valve will close at this phase. Next, diastole will start. Diastole will start with the isovolumetric relaxation. It will last from the closure of the AV valve, aortic valve, until the mitral valve opens. So when the mitral valve opens, again the isovolumetric contraction will, ejection phase will start. So next will be a rapid filling phase. So when the mitral valve open, the blood from the atria will go into left ventricle, rapid filling phase, and then diastasis, and then atrial systole. So there are 3 phases, 3 subphases in systole, and diastole as 4 components. So just hold on. Okay. Okay, before we go further, just know the rough anatomy. Just want to recap. So don't get confused with the name of the valves and everything. So right atrium, left atrium. From the right atrium to the right ventricle is tricuspid valve. It's the AV valve, one of the AV atrioventricular valve. Okay. So right atrium to right ventricle is tricuspid valve. Left atrium to left ventricle is mitral valve. Pulmonary, artery and vein got pulmonary valve. Pulmonary artery mainly got pulmonary valve. We talk about it, pulmonary valve. Then your aorta got aortic valve. Okay. So when there is a right atrium, blood from right atrium will go through mitral tricuspid valve to right ventricle. From the left atrium will go through mitral valve to left ventricle. Blood from the right ventricle will go into pulmonary artery via pulmonary valve. Left ventricle will eject the blood through aortic valve into your aorta. During the cardiac cycle, we will concentrate mainly on the left side of the heart. So the cardiac cycle graphs and the pressure all will be related to the left side of the heart. So it's left ventricle and aorta. So the phases of the cardiac cycle, as I mentioned, atrial systole begins. It correlates with your P wave, is atrial diastole. So atrial systole will contract and forces blood into the ventricle. Then the ventricle systole starts. Okay, one complete sequence of systole and diastole, right? So ventricle systole starts. The ventricular contraction pushes the AV valve open. Okay, your aortic valve open when there is an increase in pressure in the left ventricle. The aortic valve opens and the blood will be ejected into your aortic valve. Okay, so and the AV valve here, the atrioventricular valve, when they mention AV valves are mitral and tricuspid. So the left ventricle, you look at the left ventricle. So the mitral valve is now closed. Okay, mitral valve and tricuspid valve is closed. The semilunar valve, which is aortic and pulmonary valve, will open during the ejection phase. So the blood will be ejected from the ventricle into the pulmonary artery for the right ventricle and aorta for the left ventricle. Okay, so this is later it will go into a diastole where semilunar valves close, mean eject aortic valve and the pulmonary valve will close and mitral valve and tricuspid valve open, and the blood will fill the ventricles from the atria. So the most important graph that we have to know, or the pressure volume, the pressure time loop that we have to know in cardiac cycle is this, which is known as the left ventricle or aorta pressure time curve, or it's given a name by Wiggers diagram. So the Wiggers diagram, it has a pressure on the y-axis and time on x-axis. This is the time. Okay, the x-axis will be time and the y-axis will be your pressure. So there will be a multiple superimposed curve over this along with the time. So the first one you all want to look at it is the blue color one. The blue color one is the ventricular pressure. So left ventricular pressure curve, the blue. Then you look at the red one. Red is the aortic pressure curve. Okay, this is the aortic pressure. This is the left ventricular pressure. And the yellow or brown one is the atrial pressure curve, which also corresponds to your CVP. Okay, sorry. So ignore this lower part for now. We'll start with the upper part first. So what happens? First, with the beginning of atrial systole, atrium is contracting. So the blood has been filled into your ventricle. So during this phase, the left ventricle is filled. And left ventricle filled, that is when the systole of the left ventricle starts. So when left ventricle systole starts, the mitral valve is closest because the blood pressure in the left ventricle exceeds the blood pressure in the left atrium. So they shut the mitral valve. When the mitral valve is closed, now the left ventricle is a closed cavity because mitral valve is closed and aortic valve is not yet open, still closed. So there is no change in volume now, and because of the volume has been filled, the pressure builds up in the left ventricle. The left ventricle pressure slowly shoots up until it reaches up to 80 millimeter mercury, where the pressure of the left ventricle exceeds the pressure of the aorta. So when the aorta, the left ventricle pressure exceeds the aortic pressure, it will force open the aortic valve. So when the aortic valve opens, that's when the rapid ejection phase starts. Because the left ventricular pressure is higher than aorta, the blood ejected from the left ventricle into the aorta. So there is the rapid ejection. So when there is rapid ejection, the pressure in the left ventricle is increased further. At the end of rapid ejection and when we are going into the reduced ejection and protodiastole, the pressure in the left ventricle will slowly comes down. When it goes below 100 to 180, the aortic pressure is now high because blood is being filled into that. So during this phase, since the aortic pressure is now higher than the left ventricle, the aortic valve closes. So this is the phase when the left ventricle pressure drops below the aortic pressure, the aortic valve closes. And the left ventricle pressure will continues to fall. This is the phase of isovolumic relaxation. Diastole has been started. This is diastole. This phase is all diastole. Okay, where diastole has been started. The aortic pressure, you can see a small incisura here. This is because there will be a small backflow of blood from your aorta into your aortic valve, which causes a dicrotic notch. We call it a small regurg or small backward flow of blood. So the left ventricle pressure will continues to fall where it falls beneath the atrial pressure. So when the atrial pressure supersedes the left ventricular pressure, the mitral valve force opens and blood being ejected again, means left ventricle being filled again from the atrium. So this cycle continues again. The left aortic pressure was high because it receives the load amount of blood from the left ventricle, but it continues to drop as the blood being sent to the periphery or distal circulation. So this is about the left ventricle pressure and also the aortic pressure. I just want to re-emphasize here. When the pressure of the atrium is lower than the ventricle, means the left ventricle pressure higher than the atrium, the mitral valve closes. Ventricular pressure higher than the atrium, the mitral valve closes. When the ventricular pressure higher than the aortic pressure, it forces open the aortic valve. When it falls back beneath the aortic pressure, aortic valve closes. And once again, at the end of isovolumic relaxation, at the end of this, when the mitral valve opens, it means the aortic pressure is higher. So here is the volume. As we mentioned here, look at the isovolumic contraction phase. The volume of the left ventricle remains static, that is isovolumic. But during the ejection phase, the volume rapidly decreases because blood being ejected into the aorta. Then isovolumic relaxation. Again, during this phase, there is no change in volume because there is no filling occurs yet. This is the early part of diastole. During the early part of systole and the early part of diastole, there won't be any change in volume. They are getting prepared to start their phase. So during that part, there is no change in volume. Later on, there will be a rapid inflow, rapid filling phase and slow filling phase. Then continues to be the last part of the diastole, where last part of the left ventricular filling is contributed by the atrial systole, which is the last 30% of the left ventricular filling. So this is about the ventricular volume along with your cardiac cycle. Then we look at our ECG. Your systole will correspond with your QRS complex. At the beginning of your systole is your QRS complex. Your atrial systole corresponds to your P wave, and your repolarization, your diastole will correspond with your T wave. T wave. P will correspond to the beginning of atrial systole. QRS will correspond to the beginning of your ventricular systole, and T will correspond to your repolarization phase, beginning of repolarization phase. And your first heart sound is at because of the closure of your AV valve. Mitral valve. It is because of the closure of your mitral valve. The heart sounds are always because of the closure of the valves. The first heart sound is at the beginning of the systole because of the closure of your mitral valve. And the second arch sound is because of the closure of your aortic valve at the end of the systole. So we'll just go back again. So repetition. The left ventricular systole starts with the beginning of the, we look at the atrial systole. When the atrial systole completes, your left ventricular systole begins. During this phase, the pressure in the left ventricle rises rapidly. So during the rapid increase of the pressure, it supersedes the atrium and the mitral valve close, causing the first arch sound. AV valve remain closed, mean aortic valve is still closed until the left ventricular pressure exceeds aortic root pressure, say 80 millimeter mercury. During this phase, the left ventricular pressure volume is static. That's why isovolume. When the left ventricular pressure supersedes the aortic pressure, AV valve open, aortic valve open, rapid and reduced ejection phase occurs. During this isotonic contraction, final part of the ejection, during this phase, left ventricular pressure drops below the aortic pressure. Protodiastole, no ejection occurs, but the pressure in LV continues to fall. Pressure in LV continues to fall, but there is no change in volume, this short phase, until a phase when the pressure is dropped below the aortic pressure and AV. At this part, you can see when the aortic valve is closed during this area, the aortic pressure is higher than your left ventricular pressure, than your aortic valve closure. So similar changes occur in the right ventricle and pulmonary artery. Now we are talking about left ventricle and aorta, but the same thing could occur in your right ventricle and pulmonary artery as well, just that the pressure on the right side of the heart is much lower. The peak right ventricular systolic pressure is maximum 20 to 35, and pulmonary diastolic pressure will be 8 millimeter mercury. So valve involved will be tricuspid and pulmonary. Here the valve involved is mitral and aortic. That's the difference. So we go back again. I just want to repeat multiple times so you all understand very clearly. At the beginning of left ventricular systole, your mitral valve opens. Okay, mitral valve closes. Mitral valve closes. AV valve here stands for atrioventricular valve, mitral valve, atrioventricular valve, which is mitral. Between atria and ventricle, it's a mitral valve. So mitral valve closes, and then your aortic valve opens, ejection starts, then your aortic valve closes, then your mitral valve opens again. Don't confuse with my short form AV here. The AV here in this picture corresponds to your mitral valve, atrioventricular valve. Aortic valve is different. In my slides, I use AV as aortic valve, MV as mitral valve. Okay, the pictures are different. So it's all is the same beginning here. You can correlate with this picture and multiple picture. Learning CVS and cardiac cycle or anything related to CVS, you have to look at a lot of pictures. Google's and internet got a lot of multiple animation and pictures and videos. Please look through it multiple times. Then you will know which one is the best one for you to understand. Okay. Wiggers diagram, you have to look at the picture. Choose the one that you feel comfortable. I always use this as the most complete information. Stick to it and try to draw it multiple times, because if you go for primary viva, they will ask you to draw this LV and aortic pressure curve. So next, we talk about systole. Then what happens in diastole? In diastole, now this is the part that diastole starts. During this phase, both aortic and mitral valve are both closed. Now a left ventricle is a closed cavity. So there is no change in volume, but the pressure in left ventricle falls rapidly to almost zero. This is the pressure dropping to zero. Okay. We look at this picture. Yes, this is the part that your diastole start, isovolumic relaxation, your pressure begin to drop. There will be a mild retrograde flow in proximal aorta, causing small rise in pressure, dicrotic notch. This is what I mentioned as your dicrotic notch. Small backward flow causing a small regurg or increase in pressure causing dicrotic notch. This is characteristic nature of pulsatile flow in your aorta. Then left ventricular pressure drops below the LA pressure. Left ventricular pressure drops below the aortic pressure and mitral valve are open, forced open. And the mitral valve open, left ventricle fill rapidly after the mitral valve open. The blood from atria now filling the left ventricle. There'll be a rapid filling phase where there's 60% of the left ventricle being filled. And there'll be a diastasis phase where another 10%. And the diastole is being completed by the atrial systole with 30% left ventricle filling from atria, left atrium. So this is atrial kick, which is the last part of the diastole, where atrial systole is important to complete your left ventricle filling. So this is called atrial kick. It is contribute up to 30% of your left ventricular filling. Remember these values. These are important in MCQs. The 60%, 10%, 30%. The importance of this atrial kick is in pathological condition. In let's say in AF, atrial fibrillation, there is increase in heart rate. So they supposedly, when there is increase in heart rate, the left ventricular filling will be more, but the rhythm is very irregular. Your atrium is fibrillating. So because of that, the filling is impaired. So the atrial kick is impaired. There is less left ventricular filling, will cause for less cardiac output. That is why in atrial fibrillation, we get hypotension. Understand? So that is the reason why, one of the reasons why patient with atrial fibrillation will need inotropic support, because their rhythm is irregular. So the atrial kick, which contribute to 30% of the left ventricular filling, is being compromised. So this is again a repetition. So go through it on your own. I just shared few pictures which I think can explain better. This is with the pictures of where it's being ejected and everything lah. So we don't have to go through it again. Just remember, QRS corresponds to beginning of systole. Okay, your T as ventricular repolarization is during the diastole, end of systole and beginning of diastole. Okay, and your P corresponds to your atrial systole. So another important thing that we have to know is this graph, the right atrial pressure curve, or also known as CVP waveform. It is out of scope for today's topic, but it is important for you to know. It is a famous MCQ question. I have shared the notes here. The CVP waveform at A, C, and V wave. So A wave, C wave, and V wave. So you look at it, A wave, C wave, and V wave. Each corresponds to one phases of cardiac cycle, and X descent and Y descent, which is also corresponds to certain part of your cardiac cycle. You have to know this, and you have to know what are the mechanical events occurring during this phase, because these are all famous MCQ question. And again, this is a repetition, and electrical activity first, then only muscle contraction. So you will see the ECG waveform first before the CVP waveform. If you correspond your ECG to your waveform, you see your P comes first before your A. The A wave in your CVP correspond to atrial contraction. So it is a mechanical activity. So the mechanical activity comes later. Your P wave, electrical activity, comes first, followed by your C wave, which is your early systole of your left ventricle. So your QRS comes first, then only C comes first. This is your electrical activity. This is your mechanical activity. Okay. So this is how you have to read this CVP. This is for homework. Please read it up on your own. This is not covered until today's time. Then you can look at it all this way. R wave, then C wave, and T wave, and your V wave. P wave and P wave followed by your A wave. R wave followed by your C wave, QRS complex R wave, and T wave followed by your V wave. So repolarization V, which is followed after a T, you get your V, which is repolarization. And another important scope of this CVP waveform is in pathological condition, what are the abnormalities you will see in this atrial pressure waveform or CVP waveform. So this is the summary of it. If A wave, where it will be lost, where it will be increased, where it will be big, everything I've put in here, please read through. You can always look into your CVP waveform in pathological condition. They will come with a lot of things. Like, let's say you can see here, the C wave, the tricuspid regurgitation causes fusion of C and V wave. The V wave will be increased in TR, tricuspid regurg, these kind of things. This is for your own homework. So next we go to coronary blood flow. Because before we go to coronary blood flow, does anyone wants me to repeat cardiac cycle? Any phases of the cardiac cycle? Let me know now before we move on to your coronary blood flow. All clear? I'll wait for 10 seconds. If no one say anything, then we will continue with coronary blood flow. All good? Okay, good. So let's move on. So next we go into coronary blood flow or coronary circulation. So again, anatomy. What we have to know about your coronary blood flow is right and left coronary arteries. Where do they come from? From your aorta. So these left and right coronary artery will give out multiple branches and eventually they anastomose with each other, supplying different regions of the heart or different wall of the heart. So first we'll talk about arterial supply before we go into venous. I always keep this picture from my beginning of my NS career, before I sat for my MCI, even before masters. This is the same picture I always refer to, and I might make my notes based on this picture. So you choose whichever picture you think complete for yourself, and then make sure you look at this picture multiple times so you can imagine it whenever you have a question regarding coronary circulation. Then you try to come up, read the notes and come up with your own diagram or own kind of flow chart, how the blood flow actually occurs in the coronary circulation. So this is the way I did my coronary circulation diagram, with few important information into it, which is related to MCQ, where they will ask this very minute details in MCQ, where it arises from, how it arises in front or post, in front or behind, how many percentage and everything. So I will go back and forth within this diagram, my notes and this diagram to explain better. My notes are based on this diagram. So first, as I told, the coronaries are arising from ascending aorta. So where they arise, this is an important MCQ famous, it arises both the right and left coronary. They are being given out branches from the ascending aorta superior to aortic valve. It means it's above the aortic valve. They always ask inferior, posterior. No, it is superior to aortic valve. So ascending aorta at the location of superior to aortic valve, it gives out left coronary artery and right coronary artery. Another important minute detail is right coronary artery. So we don't see aortic valve here, but this is aorta, this is aortic valve. So you can see aortic, your coronaries are coming above, superior to your aortic valve. Right coronary, left coronary, superior. Okay, that is one information. Next, your right coronary artery, it comes in front of the pulmonary trunk. Pulmonary trunk as in pulmonary artery trunk. So the pulmonary artery goes behind the aorta, but the right coronary artery, it comes in front of the pulmonary trunk, in front of the pulmonary trunk. Whereas your left coronary artery, it comes behind the pulmonary trunk. It behind the pulmonary trunk. So that is another important information in MCQ. So right is in front, left is behind, but both arises superior to aortic valve. This is your aortic valve, superior to aortic valve. Okay, next. The right coronary artery supply 1/7 of the total coronary blood flow. The 6th or 7th, almost 90% of the coronary blood flow is supplied by the left coronary artery. This is also another important information. 1/7 is by the right coronary artery and 6/7 is by the left coronary artery. Which area they supply, we will talk about it a bit later. Okay. Another information I mentioned here is the aortic sinus, because both the right and left coronary artery, they arises from the ascending aorta superior to aortic valve at the aortic sinus. Both at the aortic sinus area. What differs is one is behind pulmonary trunk, one is in front pulmonary trunk. That is the difference. Okay, now we look into right coronary artery first. Focus on the right coronary artery. If you look at the right coronary artery, this over here, this is right coronary artery. So it once after it originates from your ascending aorta, it runs in the right atrioventricular groove. It runs in the atrioventricle. This is your atrium, this is your ventricle, this is the groove. It runs in the right atrioventricular groove until it reaches the inferior border on the right side. It reaches the inferior border on the right side. This is the inferior border on the right side, where it gives out two branches, right marginal branch and the main stem as run on the posterior interventricular groove. So you look at it, the right coronary artery runs in the right atrioventricular groove, and when it reaches the inferior border on the right side, it gives out a marginal branch, right marginal artery, before it takes a U-turn and runs on the posterior interventricular groove. This is posterior interventricular groove on the right side. Anterior interventricular groove, then posterior interventricular groove. It gives out a right marginal artery before it actually runs on the posterior part of the right side of the heart. So in right anterior interventricular groove, anterior side, it goes inferior border, gives out a marginal branch. The marginal branch is supplying the apex of the heart. This is the right marginal artery. This is your apex of the heart. It also partly supplies the apex of the heart. Another part comes from the left coronary artery. We'll discuss later. So this is the apex. And the branch goes behind, runs in the posterior interventricular groove, and also gives to apex as well. Sorry. It also runs in the posterior interventricular groove, gives us the branch to supply the apex also. This one, the posterior descending artery also supplies the apex, and the right marginal branch goes to apex as well. And then at the terminal part, the terminal end of the RCA, anastomosis with left circumflex at the posterior anterioventricular groove. So if you look at it, this is your, sorry. Your left circumflex, this is your left circumflex. The left circumflex has a branch here, the behind here. So this posterior descending artery will run here and will anastomosis with it later, this part. So don't worry about it. Remember this part, initial right atrioventricular groove, it gives out the right marginal branch, and then it runs at the posterior interventricular groove. It supplies the apex and it supplies the posterior. So that's why right atrium, the right RCA supplies the inferior border of the heart and also the posterior part mainly. Right side of the heart where the inferior border and the posterior. So now we go to left coronary artery. Left coronary artery, it runs in the left atrioventricular groove. This is your left coronary artery. It initially runs in your left atrioventricular groove, atrium, ventricle, left atrioventricular groove, before it branch out to two main. This is your left main stem, where you always say stem, right? This is the left main stem. This is your left main stem. Runs in your left atrioventricular groove before it branch out to left circumflex artery and left anterior descending, LAD. Left circumflex and LAD. So the left, we talk about LAD first. The LAD will give out a diagonal branch and also it will continue to run in the atriointraventricular groove until it reaches the apex. So the left circumflex gives out a diagonal branch. Sorry, this is LAD here. We're talking about LAD now. So the LAD gives out a diagonal branch. During our OT, they always mention, right? So it gives out a diagonal branch and then it continues to run in the interventricular groove, as also known as interventricular artery, left anterior descending, all the way until apex, where it takes a turn and goes behind and it will connect with your right side of the artery, anastomose with the right coronary artery. Okay, so the left anterior descending, it runs on the anterior part of the interventricular groove. It gives out diagonal branch and then it runs all the way until apex and you take a U-turn and then it will connect with your posterior descending artery from the right coronary artery. So left anterior descending will anastomose with posterior descending artery from RCA. You can see these are two being anastomosed. Okay, now we talk about left circumflex artery. So left circumflex, it will run in the atrioventricular groove where it gives out marginal branch. LAD gives out diagonal branch. Left circumflex gives out a marginal branch. So it gives out a marginal artery and then it takes a turn into the lateral border of the heart. Lateral border of the heart. It runs in the posterior atrioventricular groove and it will anastomose with the terminal end of RCA. The left circumflex at the lateral border of, take a U-turn, goes behind the posterior side of the heart, will connect with the terminal end of the RCA. So as we can see here, the left coronary artery gives our left anterior descending, supplying the anterior wall of the heart mostly, and the left circumflex supplies the lateral wall of the heart with the marginal artery and also by going behind the heart at the lateral border. Roughly, this is how we know. So right coronary artery supplied right side of the heart, inferior border, this is your inferior border of your heart, partly supplies the apex also and the posterior part mostly. Left circumflex supply the lateral wall and also mostly the lateral wall of the artery. Left anterior descending supplies the anterior border and also a part of the apex. We'll go into this, relating it both later. So this is my simplified diagram. You all can look at it again later. So the left circumflex supply the lateral border. In your ECG, it relate to your V5, V6, 1 and AVL. So a patient come with STEMI with this elevation during this region, lateral wall is involved. Mainly left circumflex artery is the one as occlusion. Let's say patient come with anterior or septal region, then it will be left anterior descending. If the patient comes with inferior MI, anterior infarct, or because the anterior infarct V3, V4 or inferior MI, then it will be RCA territory. That's how we know. So again, another thing we have to know is which part they mainly supply. So the right coronary artery, as I mentioned, is mostly in the right side, right atrium, right ventricle. It supplies the 60% of the SA node, 90% of the AV node. All these figures are important for MCQ, your MEDEX. It can be asked. It also supplies the left atrium partly, and it supplies the interventricular septum. Your left coronary artery supply the left ventricle, left atrium majority, atrioventricular septum, right atrium as well, and SA node 40%. SA node here is 60% by right coronary artery, left coronary artery 40%. But the major portion, which is the big chunk of the myocardium, is supplied by the left coronary artery. Again, we go back to this. You try to make your own notes and read with these notes. I've sent a video. You all can go through YouTube. There's a lot of videos actually shows this coronary circulation along the explanation. So important values to remember. Your coronary blood flow is 200 to 250 mils per minute. What the percentage of the cardiac output that goes into coronary blood flow? Only 5%. because your cardiac output, let's say take it to 5,000 mil per minute with each cycle, but only 250 mil goes into your coronary circulation. That's why it's 5% only. Comparatively, renal receive 25% of the cardiac output, brain receive 15% of the cardiac output, liver receive 30%, GIT receive 20%. Out of all these organs, brain is constantly functioning, but heart is constantly beating. And they are one of the most active organ of your body and most crucial organ of the body to keep you alive. But how come they can sustain? Because your blood flow guarantee your oxygen supply. So how come only with this limited and one of the lowest circulation, they can stay alive and sustain with the blood flow of only 250 mils per minute compared to other organ? Any idea? Anyone can answer? The answer is here. So the answer would be because they have a very high myocardial oxygen extraction ratio. What is myocardial oxygen extraction ratio is? Each organ have their own oxygen extraction ratio. Let's say you are giving them 100 ml of blood. Out of the 100 ml of blood, how much oxygen they can extract out? Some of them only have very limited, some of them very high. The myocardium has a very high oxygen extraction ratio, up to 65% when it's needed, compared to brain, liver, renal, or anything. So they can extract most number of oxygen from the limited blood supply. That's why they can stay sustained. But if there is increase in demand for oxygen, let's say during exercise, they cannot extract anymore because they're already extracting almost 65%. They cannot supply the demand by increasing the extraction. They have to have an increased blood supply. That is why during exercise or any strenuous activity, your blood supply will increase by 5 times to coronary circulation. This is the significance or application we do in stress test, treadmill stress test. We want to see whether a patient can increase the coronary circulation or not. Let's say they cannot increase the circulation, it is suggestive of coronary occlusion, then ischemia occur. That is when the patient will have chest pain, angina, or desaturation or hypotension. Then we will know this patient has coronary occlusion. He cannot, his myocardium cannot sustain a continuous or increased blood circulation during a strenuous activity. So that will suggest a patient to have an angiogram to rule out coronary occlusion. Before I move further, so far anyone has any question? To be honest, these topics are well taught in face-to-face, physically, so we can draw and explain. Over the virtual, all these are limited opportunities. So if any question, you can stop me anytime and ask. Next, we have to relate our coronary blood flow to cardiac cycle. So how do we relate? Your left ventricular pressure increases during your systole and it drops during diastole. This change in pressure during during cardiac cycle in left ventricle and aorta is very important determination of your blood flow to your coronaries. Your coronary blood flow for the left ventricle occurs predominantly during diastole. This is your coronary circulation. This is blood flow. This is not pressure. This is flow in milliliter per minute. The up there is your aortic pressure. You can see your left coronary, the blood circulation mostly occurs during your diastole, where in systole, especially during the beginning of your systole, it almost goes to zero. There is no blood coronary circulation at all during your systole in left coronary. Coronary blood flow left ventricle occurs predominantly during diastole. The subendocardial flow in left ventricle ceases during diastole, very less. These are all important words for your MCQ. Because of lower pressure in right ventricle, if you say right coronary and your right ventricle, the difference in flow between systole and diastole is much less than left ventricle. So you see in right coronary, during systole and diastole, the circulation is still occurring in both. But in left coronary, the difference is very big in systole versus diastole. Why is it so? As I mentioned, your coronaries arises from your ascending aorta above your aortic valve at the aortic sinus level. Okay. When there is increase in your left ventricular pressure, your left ventricular pressure supersedes the aortic pressure and there will be occlusion or almost nil perfusion from the left coronary. But during diastole, the left ventricular pressure is much lower than your aortic pressure and the coronaries opens up and the blood flow continues. Your coronary perfusion pressure, this is the equation that you know. What is coronary perfusion pressure? It's a driving pressure for coronary circulation. So coronary perfusion pressure is aortic pressure minus left ventricular pressure or right atrial pressure. This is resemblance of coronary sinus. Don't pay much attention now to this. Just pay attention to aortic pressure minus left ventricular pressure. So when there is a large difference between aortic pressure and left ventricular pressure, there will be more coronary flow. As I mentioned, during systole, the left ventricular pressure is very high. So the difference between aortic pressure and left ventricular pressure minus will be very low, so lesser coronary flow. But during the diastole, the aortic pressure is way higher than your left ventricular pressure. So there is a significant difference. So that is why most of the left ventricular flow occurs during diastole. So aortic diastolic pressure minus left ventricular diastolic pressure. So we go back to this. We look at it, systole and diastole. The blue is your left ventricular pressure. Your red is your aortic pressure. During systole, the difference between aortic pressure and left ventricular pressure is very little, and most of the time your left ventricular pressure is higher than your aortic pressure. That is why during this period, almost nil or negligible coronary circulation occurs. Okay, but at the diastole, you can see your aortic pressure is higher than your left ventricular pressure almost all the while. So that is why the coronary blood flow occurs most of the time during your diastole period of your cardiac cycle. Okay, this is about cardiac output. That we are talking now about coronary circulation, blood supply to coronaries alone. So this is how we relate. We talk about it here again. Coronary perfusion pressure is equivalent to aortic pressure minus left ventricular pressure. So during systole, this is the beginning of systole, we see the pressure of left ventricle is under 20 maximum. The pressure of aorta also under 20. So under 20 minus under 20 is almost zero or very negligible if there is much of a difference. So that is why the blood flow is very insignificant during your systole. This area, this is systole. Okay, but let's look at it during diastole, left ventricle and aorta. During left ventricle, during diastole, the aortic diastolic pressure here, this is diastole is 80, almost it comes down to 80 here, aorta. But your left ventricular diastolic pressure goes all the way down up to 10. So 80 minus 10, 80 aortic pressure, left ventricular pressure is 10. 80 minus 10, you have 70 millimeter mercury of the differences. That is why your coronary circulation, left coronary circulation is very high during your diastole period. Okay, this area. So now we talk about right atrium and right ventricle and right atrium, the differences. It's not much. You see, during systolic, your differences between your right ventricle and right atrium, 25 minus 0 is quite high. Still, that's why it's maintained. And even during diastole, difference is 10 minus 4, 6. Still there is a significant difference. That's why the blood circulation in right coronary is maintained, because the changes or differences between the arterial pressure and your left ventricular pressure is not so much. Look at it, right ventricle and pulmonary artery. Here is left ventricle and aorta. Here we're talking about right ventricle and pulmonary artery. Okay, that is the difference. So next, how we're going to relate our coronary circulation to ECG. This is what I've summarized in my notes here, the ECG and also the which wall of the heart with the artery. So this is just another way of looking at it. So your circumflex artery, which supplies the lateral wall, will be signified in your lateral leads, which is 1 AVL, V5 and V6. You look at your aorta, gives out left coronary artery. So left coronary artery got left circumflex and left anterior descending. Your left circumflex is here. This area, V5, V6, 1 and AVL. So it supplies the lateral border of your wall, lateral border of your heart. So left circumflex artery, lateral wall. If there is ischemia, it will be shown in 1 AVL, V5 and V6. Your inferior border is supplied by right coronary artery, which is shown in 2-3 AVF. 2-3 AVF. Your septum and anterior wall is mainly supplied by your left anterior descending. If there is a septal involvement, main part, that is your proximal LAD, you will get V1 and V2. With your distal LAD, you get anterior wall, you get V3 and V4 involvement. Your coronary circulation to the conducting system of your heart, mainly, as I mentioned, the RCA is the main one supplying SA node up to 60% and AV node 90%. So any problem in the conducting system of the heart, if there is arrhythmia, the most probable reason of occlusion is in the right coronary circulation. You see, it supplies majority. We go back to my notes. You see, 60% of the SAN and 90% of the AVN is by the right coronary artery, whereas the SAN is only supplied 40% by the left coronary and 10% by the left coronary. So the main chunk of the conducting system is by the RCA, right coronary artery. But the main chunk of the muscle mass of the heart is supplied by the left coronary. So left coronary is for the myocardium, for the muscle mass, for the contractility. But for the rhythm, for the rhythmicity and automaticity of the heart, your right coronary is the most important. Your LAD, which is left, do supply your AV node. It doesn't supply much of the SA node, but they have 40% there, and they supply the other part of it as well. But the main chunk is from the RCA. Okay, the left coronary artery by LAD and left secondary, they do supply, but the contribution is more by the RCA. So this is again a repetition and a summarized form I found in the internet, which is very good. If you look at it, sinoatrial node, 40% by the RCA, 60% by the RCA, 40% by the left circumflex. The numbers all you must know. All these are very famous if CVS MCQs. This 90%, 60%. 60% SAN by the RCA, 40% by the left circumflex. Atrioventricular node, as I said, 90% by the RCA, 10% for the left circumflex. So left circumflex do supply both SAN and AVN in a smaller contribution. Right bundle branch is mostly by your LAD bundle branch, but it also receives RCA as well. His bundle, the upper part, is mainly from RCA. So the conducting system at the beginning period, SAN, AVN, and the bundle is by the RCA. As they go below towards the apex and the main muscle mass of the ventricle, they have more contribution from the left coronary circulation. So now we go to venous drainage of the heart. Okay, regarding the venous drainage of the heart, no need to know in much very detail. Just remember few salient points is enough. Okay, so the most of the blood drains into the right atrium through the coronary sinus. Coronary sinus receive 90% of the venous drainage, And another 10% is by the Tibial veins and small cardiac veins, which they directly drain into the right atrium. What is coronary sinus? Coronary sinus is a dilatation of your great cardiac vein. Okay, is a dilatation of coronary sinus, dilatation of the great cardiac vein. This is another MCQ. They will put anterior cardiac vein, middle cardiac vein. No, it's a dilatation of great cardiac vein located in the posterior part of the AV group. They are located here. This is posterior. Anterior, posterior, they are behind. So when you're pushing the eye in the posterior, you can see it properly. Okay, this is great cardiac vein. When it comes, it dilates. When it dilates, it is called coronary sinus. It is very near to IVC. Great cardiac vein dilatation is called coronary sinus. They receive 90% of the venous drainage. They lies in the posterior part of the atrioventricular groove near the IVC opening. All these words you must know. They can just change anterior part of the atrioventricular groove. They can change greater cardiac vein to middle cardiac vein. It's a continuation of the great cardiac vein. It's a dilatation. Opens into the right atrium to the left of the inferior vena cava. To the left. They will put right of the inferior vena cava. MCQs are always like this. They are just to mess up your brain. They will just change one or two words. So all these are important. The left of the inferior vena cava. It lies on the posterior part of the interventricular groove. It's a dilatation of great cardiac vein. It's right on the left inferior. It receives 90%. They have tributaries which runs into the posterior coronary sinus. Small and middle cardiac vein, posterior vein, all these runs into there. There are anterior cardiac vein which doesn't drain into coronary sinus. They drain directly into the right atrium. This is anterior cardiac vein. Because the coronary sinus is the posterior part, the anterior cardiac vein doesn't drain into coronary sinus. They drain directly into the right atrium, but they are very small portion. 90% is by the coronary sinus, and another small insignificant amount by vena cauda minimi, open directly into arch chambers, directly into right, left atrium and ventricles. And we have a Tibial veins, also a very minimal contribution. They also directly drains into left heart. Again, about coronary sinus, because it's important part of the venous drainage. The heart is drained by coronary sinus, which empties into right atrium. That it is a dilatation of great cardiac vein. Two sets of veins actually drain into coronary sinus. Vena cauda minimi. Other veins that doesn't drain into coronary sinus, but they empties directly into right atrium is vena cauda minimi, anterior cardiac vein. The coronary sinus opens into right atrium between IVC and tricuspid opening. Okay, guarded by incomplete semicircular tibial valve. This is not so important. The tributaries all have valve except oblique vein of left atrium. This is again another MCQ. All of the tributaries have valve. All the veins have valve except this oblique vein of left atrium. This one, oblique vein of left atrium doesn't have valve. I don't know what is the significance, but it's asked in MCQ. Just remember, MCQs are like that. Sometimes you don't know what is the importance in your clinical practice, but it will be asked. Okay. Again, before we go into the last topic, autonomic innervation, any questions for those who are still here? Okay, good. No questions. So we continue with the last part, autonomic innervation. Okay, cardiac autonomic innervation is another small topic which not mostly asked in SAQ as a big question. It's asked for 2-3 marks short essay question. But MCQ, yes, it can comes out as a big stem and ask for 5 marks, multiple true, false or SBA. So you have to know the salient points. So cardiac autonomic innervation. The origin is from medulla oblongata. This is another MCQ. And it arises from nucleus tractus solitarius, NTS. I only put the important names here and the words because I don't want to bombard you with the whole origin of autonomic innervation, which is not important for our level. For anesthesia purpose, we just have to know the salient points as in for physiology. So it comes out autonomic system as sympathetic and parasympathetic. So at the level of nucleus tractus solitarius, okay, again, this is another notes I grabbed from YouTube, I think, which is very good. So you look at it. This is your medulla from your brainstem. Okay, your brainstem got pons, medulla, and brainstem, pons, medulla, and other one. Why am I? Okay, so this is your medulla. At the level of medulla, you have nucleus tractus solitarius. From the nucleus tractus solitarius, there will be two components. One is for sympathetic, one is your parasympathetic. The red color is sympathetic, the blue color is parasympathetic. Okay, we look at the sympathetic first. So from the nucleus tractus solitarius, there will be a multiple ganglion. No need to know. It will be CVLM and RVLM. This is caudal ventral this is caudal ventral lateral medulla. This is rotroventral lateral medulla. No need to know. Trust me, no need to know. Just remember CVLM and RVLM lah. But this won't be asked in MCQ lah. Okay. Caudal ventral lateral medulla and rotroventral lateral medulla. Then you go to intermedullary lateral nucleus. Okay. CVLM and RVLM, then it's another synapse at the intermedullary lateral nucleus. From intermedullary lateral nucleus, it will be given out a preganglionic fiber. It is preganglionic fiber. This is part of the preganglionic fiber, which will synapse at another ganglion. So preganglionic fiber, the neurotransmitter at preganglionic nicotinic receptor is ACH, acetylcholine. Okay, even though it's sympathetic, in your preganglionic section, it is still acetylcholine. And then will be synapse to a postganglionic fiber. Sorry, this is your preganglionic ACH. Then that postganglionic fiber comes out from thoracic 1 to thoracic 5, where at the end of postganglionic fiber, the neurotransmitter involved is norepinephrine, endogenous norepinephrine. Preganglionic ACH, thoracic 1 to 5 gives out postganglionic fibers, sympathetic, postganglionic sympathetic, which use norepinephrine. So now we go to parasympathetic. Again, from nucleus tractus solitarius, parasympathetic will have two nucleus at the beginning before they go out to vagus nerve. They have nucleus ambiguous and dorsal motor neuron nucleus. Okay, they have nucleus ambiguous and dorsal motor neuron nucleus, which will combine and gives out vagus nerve, cranial nerve 10. The vagus nerve is a parasympathetic component of your cardiac innervation, where both preganglionic and postganglionic fibers uses acetylcholine as your neurotransmitter. Preganglionic and postganglionic both uses acetylcholine. Sympathetic is cardio acceleratory. It means increases your cardiac output, increases your cardiac heart rate, it increases your cardiac contractility, increases your cardiac rhythm, everything. Parasympathetic is cardio inhibitory. They reduces your heart rate, bradycardia, reduces your contractility, reduces your rhythm, everything. Okay, this is the most how you apply clinically. If the patient has any arrhythmia or tachycardia, the reason why we will do a carotid massage is that's where your vagus nerve is situated. So you want to stimulate your vagus nerve to release more acetylcholine, so it will reduces your heart rate. This is how you relate your physiology to your clinical practice. As you can look at it, both sympathetic and parasympathetic, both are innervating your conduction system of your heart. Your SAN node, your AV node, your left bundle branch and right bundle branch. So this is how they control your conduction system of your heart. So these are again the important. Origin is from medulla, nucleus tractus solitarius. Sympathetic, you don't have to remember the nucleus much, all are competent. But remember the preganglionic is acetylcholine, postganglionic is norepinephrine. Parasympathetic, the nucleus is nucleus ambiguous, later on gives out to vagus nerve, but the neurotransmitter at pre and post ganglionic both are acetylcholine. Sympathetic is acceleratory, sympathetic stimulatory, parasympathetic is inhibitory. Next, these nerves as combined is called as cardiac plexus. Cardiac plexus is a network of nerves including both the sympathetic and parasympathetic system. It has two parts, superficial and deep cardiac plexus. This is important in MCQ. The superficial is located at the arch of aorta, between the arch and the pulmonary trunk. Okay. A deep lies between the arch of aorta and bifurcation of trachea at the behind. Okay. The superficial is located below the arch of aorta, between the parts of pulmonary trunk. The deep lies at the bifurcation of trachea. So, if you can look at it, your deep and superficial both receive thoracic for sympathetic. The yellow color is sympathetic. The sympathetic, both deep and superficial, receive sympathetic chain ganglia from superior cervical, middle cervical, and inferior cervical, and thoracic 1 to 5. This is important. Thoracic 1 to 5 cervical nerve is the sympathetic chain. Vagus cardiac branches come from superior from cervical ganglion, inferior from cervical region, and recurrent laryngeal nerve. Recurrent laryngeal nerve is a branch of vagus nerve, right? So all these are also supplying deep and superficial cardiac plexus. Parasympathetic. Sympathetic is from superior, middle, and inferior cervical ganglion and T1 to T5. Parasympathetic is from vagus cardiac branches. Innervation, conduction system of the heart, mainly the coronary vasculature to cause vasoconstriction or vasodilatation by causing autoregulation. This is how they cause autoregulation. Sympathetic will cause vasodilatation. They send more blood for coronary. Parasympathetic for vasoconstriction, and then myocardium of the atria and ventricle to contract, increase the contractility or reduce your contractility. It's just a repetition of it. We can look at it in your medulla. The nuclear tractus solitarius gives out vagal or sympathetic. Okay? And they receive receptor afferent. The cardiac afferent will give feedback to the nucleus tractus solitarius whether they should discharge more sympathetic or parasympathetic to control the rhythm, rate, and the tone of the vessels. Medulla, parasympathetic is vagal. Sympathetic goes down the medulla to your spinal cord, which is T1 to T5. Goes sympathetic ganglia, control your blood vessels, dilatation and constriction of blood vessels, and also your heart. Your sympathetic is via spinal cord, because it's thoracic 1 to 5. Your parasympathetic is via cranial nerve, not via spinal cord. So key facts about the innervation of the heart. Your parasympathetic efferent is towards the heart. Is vagus nerve, reducing the heart rate, reducing the force of contraction, vasoconstriction of the coronary artery. Okay, one thing you all shouldn't get confused regarding coronary circulation and systemic peripheral circulation is sympathetic stimulation will cause, in peripheries, it will cause vasoconstriction, like while we give your phenylephrine, norepinephrine, everything. Systemically, in peripheral circulation, it causes vasoconstriction because we need to vasoconstrict so the blood can go back to your heart to increase your cardiac output to maintain the blood pressure. Okay? Sympathetic means it must be good. Sympathetic, it must do good to your body. So in peripheries, it causes vasoconstriction to increase your blood pressure and pushing back the blood to the heart. But in coronary, if it causes vasoconstriction, it will cause myocardial ischemia. As I said, sympathetic must do good. So in coronary circulation, they causes vasodilatation. Sympathetic causes vasodilatation in coronaries. In peripheries, it causes vasoconstriction. The opposite is true for parasympathetic. Parasympathetic causes vasoconstriction of your coronary arteries, but they causes vasodilatation of your peripheral circulation, but it's not so important. So just remember the vice versa. So let's say sympathetic efferent. Efferent is towards the heart. It's the cardiac nerve from the lower cervical and upper thoracic ganglia. So lower cervical and upper thoracic T1 to increase heart rate, increase force of contraction of the myocardium. Afferent parasympathetic fiber. Afferent means away from the heart. A for away. That's how I remember. A is from away. So what they give? They give feedback to the medulla. So vagal cardiac nerve, feedback on blood pressure. Afferent sympathetic fibers, afferents to upper thoracic and lower cervical ganglia, feedback on blood pressure and pain sensation. Clinical relations, cardiac plexus injury and referred pain. When the patient have a injury to the cardiac plexus, they can have multiple arrhythmia, BP low and everything. Same goes to upper thoracic injury in a patient of spinal cord injury. That's why they have bradycardia, they have severe hypotension because the T1 to T5 is involved. So their sympathetic input to the heart is disrupted.